Yeah, Sangeet,
Yes.
it's
Thank
for
you,
you.
sir. Before I start, just all of us have listened to the classification of diabetic retinopathy as was given by ETDRS. Just one question to Dr. Ajit Babu, sir. Don't you think it is a time to reclassify now and add another stage called diabetic vitreoretinopathy when the vitreous starts involving and then the treatment definitely
Yeah.
changes?
This almost 13 years ago, this classification has been proposed. Diabetic vitreoretinopathy. In addition to advanced proliferative retinopathy, diabetic vitreoretinopathy has been proposed, but somehow it has not taken up very well. This vitreoretinopathy is required for a surgical intervention. Probably the very few numbers of the highly talented VR surgeons. That's why. So it is now your turn to classify that,
Okay.
reclassify. Because
Thank.
we have kept that classification in our operation theater in LV Prasad.
Okay.
Yeah, if you want, I will share the photographs.
Thank you, sir. So I've been kept as the last of the speakers because I think everybody feels that vitrectomy is the last option when nothing else works. So let's see. Vitrectomy for diabetic retinopathy has been indicated for such a long time now, maybe 50 years. Even the first vitrectomy, which was performed by Dr. Robert McHammer, he did it on a diabetic vitrectomy. He did a diabetic vitrectomy for a non-clearing vitreous hemorrhage. And the DRVS study we came in 1980s, and it had a longer follow-up, like 4 years follow-up, which is crucial in such a long-standing disease because smaller follow-ups doesn't matter because diabetic retinopathy is a long-standing disease, and 4 years follow-up was there. And they said that early vitrectomy improved outcomes, particularly in patients with type 1 diabetes. But still, what they said was 15 to 20% of eyes, irrespective of undergoing surgery, surgical intervention, lost vision. So that was one thing that kept the surgeons in check to go for an early vitrectomy because 15 to 20% of eyes were losing vision. But there were few drawbacks in the diabetic retinopathy vitrectomy study. One thing was that there was no intraoperative laser which was being done on these eyes. That time was not possible because of the instruments were not available. And now, because the instruments which were rudimentary at that time, which have improved a lot nowadays with improvement in technology, improvement in your machines. And what happens is, like, if we try to wait, sometimes this was one patient. I advised her to undergo vitrectomy at this stage, but she had a very severe PDR, and she went to another doctor. He did laser, and but the patient still kept on progressing. She progressed to a fibrovascular and contractile epiretinal membranes that started to develop in her eye. I advised her that you need a vitrectomy. Nowadays, we have come up with a new thing that is called the angiofibrotic switch. So once that the ratio changes between the anti-VEGFs and the CTG-VF, there is a lot of scarring which happens, and sometimes it becomes difficult to control the membranes at that time. So, but still, she underwent injections at some other place, and the membranes kept on progressing. They grew, they contracted to give rise to tractional retinal detachment. And then the breaks developed and led to a combined retinal detachment. And then she came to me and asked me, Doctor, now you can operate. Okay, I said, I will still do it, but the prognosis is not as good as if I would have done at the first stage. And but these membranes are definitely difficult to treat because these are not the membranes that are like the epiretinal membranes. You just peel them off. They are multiple at the levels of where the new vessels are. They are glued. They are nailed at that points, and you have to take care. If you pull the membrane, they are just going to bleed and cause breaks. So now we recently had a study, and my previous speakers have discussed on this in DRCR protocol S. And they compared laser with anti-VEGF injections, and all these patients were on strict monthly follow-up. But at 5 years of follow-up, see, I told you diabetes is not a short disease, it's a long-standing disease. 51% of these patients needed supplement laser even after completion of PRP. And they also needed an average of 5.4 injections were needed in addition to the PRP they had undergone. And even after that, 46% still developed vitreous hemorrhage, 12% developed tractional retinal detachment, 4% developed neovascular glaucoma, and around 30% needed vitrectomy in both the arms, whether it was laser or whether it was injections alone. So despite, and you see what, this is a trial in which every patient was followed every month. And if you come to real world, so there are almost 25 to 50% miss their appointments due to either they get ill or they are non-compliant or there are some financial considerations or their age does not allow to move them every month. So real world is totally different from what is happening in trials. And 33% of eyes treated with anti-VEGF developed TRD as compared to 2%. However, this was one of the good things that they pointed out, that anti-VEGFs alone caused more TRDs as related to PRP alone. And these patients, they had advised them surgery for their TRD, but the patient had gone to somebody else, and then they had injected, and you see there is a crunch effect. There is a formation of retinal breaks leading on to combined retinal detachments. And in the picture on your right, there was a macular hole which developed after an intravitreal injection. So you have to take care of all these complications in these patients. So now, just coming to now the standard, what are the basic indications of vitrectomy for diabetic retinopathy? They are non-clearing vitreous hemorrhage, a macula-threatening tractional retinal detachment, a combined retinal detachment, a neovascular glaucoma, if it is present, a severe PDR, which is progressing despite all the treatments, the laser or anti-VEGFs that have been given, a subhyaloid hemorrhage, or a diabetic macular edema in some cases. So for vitreous hemorrhage, what the standard is that a non-clearing vitreous hemorrhage, 6 weeks to 6 months, you have to do vitrectomy, and you can do it earlier if it is associated with an RD, with a neovascularization of iris, because you have to clear and do laser as early as possible. In patients of type 1 diabetes mellitus, which has already been proven, we have to do it faster. In patients of subhyaloid hemorrhage, because if you allow them to keep settled, toxins they develop in the central area and cause permanent loss of vision. And in patients of glaucoma patients who develop glaucoma resulting from the blood. So these are some principles of vitrectomy, the steps. So you start by clearing the media opacities, all the vitreous is cleaned, and then you create a plane of dissection. I usually start at the disc. And then you remove all these membranes, then settle the retina, and do internal limiting membrane peeling in some of these cases, then do a laser and use a tamponade if required. So, and this definitely in long term gives you better results. So here the membranes are being peeled. So now the cutters that we have, very small size cutters, which can easily atraumatically lead to removal of these membranes. Even you don't need scissors, intravitreal scissors, or other fancy instruments to get rid of these membranes. So you see we have completed the vitrectomy now, and so these are some of these patients. This patient, I remember, nowadays nobody has time in this such fast-living world. The patient had to go abroad. He said, "Doctor," I told him to wait for some time. The vitreous hemorrhage will go off, but he said, "No, I want it right now. Everything should be cured." So these are examples of patients who underwent vitrectomy for subhyaloid hemorrhage, for vitreous hemorrhage, and they improved. And this was one patient who had progression despite having multiple lasers, multiple injections, and you see after one single vitrectomy, the patient is doing well. So coming to that is when do we treat the retinal detachment? Obviously, previous speakers also spoke on it, that TRD, which is threatening the macula, or when it is a combined retinal detachment, you have to go in and you have to operate. And in these cases, as Dr. Rajiv pointed out, we give an anti-VEGF preoperatively, and it is helpful. It reduces you see how the new vessels are angry before anti-VEGF, but they calm down after giving that anti-VEGF, and you can complete your vitrectomy after that. Same patient undergoing vitrectomy again, you see there is hardly any bleeding while we are doing vitrectomy because we have given an anti-VEGF beforehand. And this is post-operative. The patient improved the vision to 6/9 and remained so without the need of any further laser or anti-VEGFs later on. And and we are now able to do all these membranes. Like even the retina surgeons also used to think these patients have no prognosis, they just won't benefit. But nowadays, with improved instrumentation, with improved techniques, we are now able to remove these membranes also, and the patients do benefit after this. And this membrane, I'm just removing with a 25 gauge needle. I am using it to delaminate the membrane, and I'm using it to cut through the vascular nails also. And you'd see just the techniques and the technology has improved, which has helped us and to take care of all these severe forms of diabetic retinopathy without causing any further trauma to the eye. And the primary aim is you should not let the patient reach this stage, but this is the post-operative, the patient has improved. And these are examples of some of these patients who definitely after surgery have benefited from the surgery. And now coming to the last part, that is the surgery for DME. We generally, what is said is recalcitrant diabetic macular edema. The tractional macular edema, the primary vitrectomy for non-tractional DME is very, very controversial subject. I'm not going to touch that. And in the subfoveal exudate. So just a quick look, this is a vitreomacular retraction. And you see after surgery, when we remove the membranes, the picture calms down. So in this patient, whether you give hundreds of anti-VEGF injections, the patient is not going to benefit till the surgery is being done. This is a patient of epiretinal membrane, improves after vitrectomy and to 6/9. And this is a patient of subfoveal exudates. In this case, we did a primary vitrectomy for DME, and after the injections, after the surgery, the patient improved and kept improved. And this is a patient large amount of subretinal exudation. She had been receiving multiple injections of anti-VEGF, but she was not improving. In fact, the exudates were increasing, but by single vitrectomy, you see the exudates started going down and they reduced. And what is what is the funda of why do we do vitrectomy for diabetic macular edema? It removes all the tractional forces at the retinal surface, which in some cases may be subtle or hidden. It reduces the oxygen consumption of vitreous, reduces hypoxia at the retina, removes the vitreous collagen on the retina, and decreases the VEGF load. And what is the role of ILM peeling? The removal of ILM ensures complete removal of posterior hyaloid. And this iatrogenic trauma causes a cascade of chemical events which leads to slowly improvement in diabetic macular edema after vitrectomy surgery. And ILM peeling also increases the release of epidermal growth factor receptor, which maintains homeostasis. Thus, the vitrectomy acts as an anti-VEGF. Now coming to the last part, is vitrectomy cost effective? Yes, it is very cost effective. It reduces your long-term treatment, and early vitrectomy reduces incidence of TRD and recurrent DME. So the key takeaways in my talk would be that vitrectomy should no longer be a last resort. It should be seen as a long-term solution for diabetic retinopathy, and early and timely intervention may, using modern vitreoretinal surgical techniques, result in a favorable outcome. With modern instrumentation, the vitrectomy has become comparatively safer and easier, and it is cost effective as compared to recurrent costs involved in anti-VEGF and laser. I don't advise you to that the first time the patient comes to you, you go with the surgery. But if the patient is not responding to your treatments with laser, with anti-VEGF, with your medical treatment, just think of vitrectomy as an early option, not as a last resort. Thank you.
Yeah. Means early vitrectomy will have a better visual results. But I have two questions to you. One is the very striking picture I have seen is repeated anti-VEGF injections in PDR with early proliferation. Vascular and proliferative membranes were there, and repeated anti-VEGF injections are given.
Yeah.
And there is so much of fibrosis that has developed.
Yes, sir.
Really striking picture, actually. This has been emphasized in this study that if the patient is not readily available for you for follow-ups or lasers are not given, this is one complication that can happen.
So I think what the recent studies show that the angiofibrotic switch, the theory which has come. Yes. Once the scarring starts, nothing can control it.
A medical case, suddenly you're turning into surgical case. So that is one thing. The second is the amount of diabetic exudates in the macular area. With vitrectomy, it is clearing. I have also done good number of cases like that. But if you see one case you have showed, there are hemorrhages which are developing at 6 months visit. What is the vision for this patient?
So vision had improved, although it is not very good, but earlier it was like counting fingers only. It has now improved to I think 660 or 636 after the surgery.
660 also
But
good.
she is now maintaining it at least.
Because if you see the macular center, there are hemorrhages like that. Because few cases, very interestingly, it will improve, but not all cases. And the plaque which forms, if it is thick and it is involving all the layers of retina, it's better not to do it.
Yeah, once the scarring process starts,
Yes.
nothing helps.
So take a good call about vitrectomy in that severe forms of diabetic macular edema. With this, I'm very thankful to all of you for attending this IC, and your presence really helps us. Any questions are there? We can. Yeah, please.
Clinically, we see the patient in the stage of severe NPDR, and we think it may progress to PDR. So then, should we do the BRP?
Yeah, you want to address? Yeah. See, the thing is, I defined you two things. One is severe non-proliferative. Second is very severe non-proliferative. Severe non-proliferative, only 15% progress in 1 year. Very less. 90% do not progress to proliferative. Very severe, half of them progress to. Means these patients are at high risk. If they don't come in 1 year's time and if there is a delay, they will be proliferative, and then there is a risk of bleeding and other complications. So those cases, it has been recommended to do the laser if you are not sure about their regularity of follow-up. Okay?
So if we are planning the captive surgery,
Yeah.
laser treatment, and what should be the ideal duration against surgery? So we wait for 3 months before.
These days, speed world, isn't, but 6 weeks minimum you should wait. They disappeared, yeah.
ILM pilling was done. During the surgery there is a risk, but I have not seen in my hands. But there is a risk. But I
Yeah.
think the earlier what people used to do was they used to create a macular hole and remove the exudates through that and then close the macular hole.
Yeah.
So I don't think.
No, it's a very valid point, because if it is a full thickness or partial thickness, but at 1 or 2 spaces it is full thickness, and you are not careful enough, full thickness macular hole can happen. For that surgical intervention, you should go around the hole and then come to the center, so that the least, and if you cannot remove the ILM completely, leave part of it. There is no harm done. Okay?
No, if the plaque is only going to be very thick, then only you have to worry about removing that. And only if it is thick and covering across all the layers, your OCT would help you to define that. In those cases, yes, it will form, because already the RPE under that is already degenerated. So is it
In those
worth
cases,
doing it? You have to worry.
We have said don't intervene also.
Yeah.
That's what we said, because improvement is less likely. Only thing is, if there are partial exudates all over, if they disappear, the field will improve. The vision may not improve, field will improve, performance of the patient will improve. For that reason, you can